And now we're on to the last video, and this is part 3, complications of second stage labor. The last one, maternal cardiac arrest, can also happen really at any time, and hopefully it never happens at all. It is actually the most rare thing you're going to see on any of these videos. The rest of them are like kind of commonly anticipated. But it's important because when it does happen, you can't rely on anyone else in the hospital to even find your unit. So you need to know what to do right away. There are many, many more complications of labor that we're not going to talk about, but these 3 you should know. So we'll start with precipitous delivery, and we kind of very humorously refer to them where I work as bibs, or the baby's in the bed. Hopefully they're not in the bed. Hopefully you were there and you responded quickly and efficiently, and aren't you the most awesome nurse ever? So the definition, the technical definition of a precip delivery is labor lasting less than 3 hours. What we typically think of as a precip delivery is the second stage that occurs with little warning and happens very quickly. May necessitate a nurse delivery. You pray that you can get a provider in there, but sometimes you just can't. And to be perfectly honest with you, most of the time when they're coming out this quick, they're mostly okay. It's the ones that don't want to come out that usually cause all the problems later on. So, usually you get a happy ending with this. You just got to know what to do and be alert. It is more common in multips, especially the ones that have small babies and huge pelvises, whatever, however you say that. But it can happen. I think most of us who've done labor and delivery long enough have delivered at least one bib. Interventions, never, never, never leave the patient. Don't leave to go get supplies. Don't leave to get help. Call out from the room. We're having a baby in room 54. And everyone knows what that means too. Kind of like shoulder and cord, only not as drastic an event. And you're going to assign roles as people arrive. Point to a person. Lindsay, go get blankets. Bob, check the warmer. You're going to need delivery instruments. Some places have what's called a precip pack. We always just have labor and delivery instruments in the room at Capitol Health. We have a table and it's got we've got a little cart and we've got a little kit. So it's not really a precip pack per se. I guess if you were out in the field or you were riding in an ambulance or you were in the ER somewhere, you'd have a precip pack. But in labor and delivery, we just have the delivery kit. And a lot of times it's already set up if we know that mom is going to deliver quickly. But if it's not, you tell someone, open the delivery kit. And if you don't have a delivery kit in the room, tell someone to go get a precip pack. Name them, point to them, get eye contact, and make sure they're getting you the right instruments. You need another person in that room who is capable of providing neonatal resuscitation in the event that that is necessary. That's an NRP certification, and it's probably any one of your labor buddies, the nursery nurses, the NICU nurses, anybody who's there who has NRP could stand in and help get that baby going if need be. And you can get any OB or midwife to attend if possible in this event. Nobody's going to say no to you. Sometimes providers are at home. They don't sit and labor sit your patients. So the labor and delivery nurse has a lot of autonomy. But the downside to that is that sometimes when you need them, they're not there. There should always be somebody in-house who can attend to an emergency. You shouldn't work in a place that doesn't have that. So what to do when you're the only one in the room? Well, put on gloves. Preferably sterile gloving, but whatever you have will do. So if all you have nearby is a pair of non-sterile gloves, use them because it's icky. There's going to be blood, there's going to be fluid, there might be meconium. Put something on to protect yourself. If you can manage the sterile package without walking away, great. But if not, just put on whatever you have. Try not to do it barehanded. It's nasty. What you're going to do is support the perineum, that area between the vagina and the rectum, with one hand, and you kind of put your palm out. I'm going to show you a video in class. There's some really good videos. And you kind of have your thumb on one side and the four fingers of the other hand on the other, and the palm of your hand is supporting that perineum and putting gentle, gentle pressure on the head. You're not pushing the head back in. Please don't think that you're going to stop this birth so that you don't have an incident report to fill out. You're just supporting so that it's not an explosive delivery. As the head is crowning, you're going to take your other hand. So your dominant hand is supporting the perineum. Your non-dominant hand is going to come up and kind of like put that little pressure on the baby's head, so that the perineum doesn't tear, and also so that the head doesn't deliver explosively and then flop down. Remember, babies don't have well developed neck muscles. So you're supporting the head, you're not pressing on it. Um, After the head delivers, feel around the neck for a cord. Now, it's useful to let that head deliver slowly. I'm just going to kind of go back up to here. The panting or blowing, that was kind of review from labor support. That'll help control the speed of that delivery. Sometimes they really won't listen to you anyway, most of the time, if they're feeling that strong an urge, but try it, see if it works for you. When the head delivers, at this point, that pressure subsides a little. Mom will pant and blow if you tell her to, and she should. So get her to breathe, blow, blow, blow. And while she's doing that, and say, don't push, you're feeling around the neck for a cord. Now, most of the time, if there is a nuchal cord, a cord around the neck, it's fairly loose, and you just kind of loop it over the head, and that's a good case scenario because, gets it out of the way. You don't want to deliver the baby through the cord. It could snap. So you kind of hope for a loose one if it's there at all, and you just loop it over the head. If it's tight and the baby is stretching against it, it's going to need to be clamped in two places and cut between those two clamps. That is not the best case scenario because now you've got a clock running. That baby's got no blood flow. So you need to get the rest of the baby out fast. The good news is, again, if they're coming this fast, the shoulders probably aren't stuck. Probably the rest of the baby is going to come out really, really rapidly. So you can tell mom to give a little push for the rest of the baby. Hold on and don't drop the kid. One thing you never, never want to do if there's no provider in the room is to what they call break the bed. That's when you take the foot off of the bed, like the bottom third of the bed comes off. And providers like to do that because it gives them a little more room to work because they've got people holding legs or stirrups holding legs, and it kind of gets them right up into the field of action, and they've got more space to work. You aren't going to do that if you're delivering this baby because, well, you know what? They're slippery. They're wet, they're gross, they're full of yuck. And the chances are, if you don't have a good grip on the kid, you could theoretically drop one. I have never done that. I've delivered a few, and I get a pretty good grip on them. But don't drop the kid. You deliver it to mom's abdomen if you can, and then, all the same stuff that you would normally do in a delivery, dry and stimulate, provide warmth. That all happens, and hopefully by that time somebody's in there helping you out. But generally, precipitous delivery, you might have to deliver the baby. Don't panic. Take your own pulse. Get lots of help. And it usually works out okay. Okay, so the last one is shoulder dystocia. Oh, not the last one, but one of our last topics is shoulder dystocia. And this is your big babies. Sometimes they get stuck by the shoulders. Remember when I was younger, people would talk about, oh, she had a 10-pound baby boy, and they treated it like it was some kind of prize she was going to win at a fair. Yeah, I bet none of them ever had a shoulder because gives you little palpitations in your chest when this happens. Okay, so shoulder dystocia happens when the fetal shoulder gets impacted on the pubic bone. There it is. And it sits there. This isn't even doing it justice because sometimes that pubic bone is kind of almost a shelf that shoulder gets stuck on. Now, ways that you can know this is going to happen. This generally happens with bigger babies. It happens with moms whose pelvises are a little smaller or more contracted. It happens in obese moms. It happens in diabetic moms a lot because the circumference of the abdomen and the chest and the shoulder area tends to be bigger than the head. You can kind of get a clue that it might be coming if your baby takes forever to engage in the pelvis. If second stage takes a really long time and that head just doesn't seem to want to make any progress. But it's a very dangerous situation. And you can see on the bottom of this graphic here, the dangers include entrapment of the cord. Well, the kid's stuck. And the cord might be stuck with it. It could be a nuchal cord. It's stretching, definitely. Everything's contracting and compressing on it. We have inability of child's chest to expand properly. So if you had a situation where you had to cut and clamp that cord, baby would not be able to compensate by fetal breathing. Severe brain damage or death if child not delivered within minutes. And that's the part that you need to know, because if we don't get this kid out, we are going to have a dead baby or a child with severe brain damage. And some of the worst outcomes I've ever seen were from shoulder dystocias. I also mentioned in the last class that some of the worst ones that I've heard about or seen came from vacuums. And you do sometimes see a shoulder dystocia following a vacuum or forceps extraction, because there was a reason that kid wasn't coming. So, interventions for this. You're going to call for help. I have a shoulder in room 6. Again, be brief. Not the time to tell the life story. O positive, rubella immune, GBS negative. None of that. Shoulder in room 6. You are going to flatten the head of the bed. Forget everything you know about gravity assisting descent. What you have here is a shoulder that's packed in against a pubic bone. And if you increase the angle, you're just going to jam it in worse. So flatten the head of the bed. Then you're going to put mom in what's called McRoberts maneuver. And this is when you bend their legs all the way back, all the way to their ears, as we say. Not quite, but almost. You are going to flex them as much as you can. And hopefully mom's got some good relaxant on board and her hips are nice and flexible. It could cause injury, and we'll discuss that later. But you need to get this baby out. The provider's got a few maneuvers. I put that in smaller font because it's not something you are going to do ever. But they're going to try and deliver that posterior shoulder by hooking their fingers through the armpit, wiggling the baby from side to side. And they can even use what's called Wood's maneuver or corkscrew, where they turn that baby 180 degrees, and somewhere in there the shoulder gets unjammed. And then there's suprapubic pressure. This is when you take the fist of your hand. You are on the bed or on a stool at this point, and you are pressing down on mom's pubic bone, but not straight down. You're going to go a little bit to the side because you want to dislodge that shoulder. You want to rotate that baby just a tiny bit, just a smidge, just enough, like Winnie the Pooh in that, when he gets stuck after he eats all the honey. If we just kind of turn you this way, turn you that way, maybe we'll get that shoulder off that shelf. And that'll be enough to dislodge. The gasket maneuver is used in some cases, especially if you have an unmedicated mom. You can get her onto all fours, and that increases the diameter of the pelvis and changes the angle. If you can get her to do that, and she's cooperative and your provider's on board with it, that has been shown to be very effective. It just doesn't always functionally work out. The provider, if none of this works, can break the baby's clavicles. And then delivery is a lot quicker. Baby may have some injury, sometimes transient and sometimes more permanent to the brachial plexus, but it's still better than a dead baby, which is what you get from our next intervention. It's a procedure of last resort. It's called a Zavanelli, and it's when you take the mom back for a C-section to the OR, you shove the head back in, and you deliver that baby. If they live, the outcome is generally not great. And most of the time, the outcome isn't even that good. Most of the time, what you get is dead babies. Okay, so we're going to talk a little bit more about McRoberts and suprapubic, and that's a good picture of it right there. You've got somebody flexing that knee all the way back. Also, it doesn't you can't really see it in the picture, but you're kind of flexing it out to the side as well. And that changes the angle of the pubic bone. It's going to take it from being sort of up and down this way to more side to side. I mean, it's a subtle change, but it's usually enough. 90% of the time, you can get a kid out just by flattening the head of the bed and putting mom's legs back. And then if that doesn't work and the provider's doing their maneuvers, that suprapubic pressure, see that fist go down on you, need to put your whole body weight down. This is terrifying to the parents. They have no idea what's happening. Half the time they're filming it because their kid was coming out. And then we had what was called the turtle sign. I'll explain that in a second. So if you've got the personnel on board, hopefully someone is standing at the head of the bed explaining this. maybe somebody who's assisting with McRoberts. You've got one leg with one nurse, one leg with another nurse, and then one of the people doing McRoberts is doing suprapubic. Maybe the person who's not doing suprapubic but is doing McRoberts could say to the mom, I know this is happening really quickly, but we're going to get your baby out. You need to push. You kind of ask the provider which side you're going to lean towards because they know which way the baby's wedged. They can feel in there, and they'll tell you which way to wiggle. Now, a word about the turtle sign. I can try and get a picture of that and show it to you in class. That's the telltale sign that you have a shoulder dystocia. So the head is delivered, and then all of a sudden, instead of doing that external rotation, it gets sucked back into the perineum, and the baby's nose is sort of buried in the perineum. That's called a turtle sign, and it looks just like a turtle going back into its shell. You see that, you just start moving and getting help, calling for help, flattening that head of the bed. Hopefully, if you're that close to delivery, you've already got someone to help you, because the standard of care should be that you have one nurse for the mom and one for the baby. And sometimes we have more than that. Sometimes our charge nurse likes to be there and they do the documenting just in case anything goes wrong. And that's a wise move if you have enough staff to do that and everybody's not delivering at the same time. But if you have to, you get help when you see that turtle sign. Let's see. And that is that for shoulder dystocia. Maternal cardiac arrest is our last topic. It is not common, thankfully, but it has happened. I would say in the last 5 years, we've had 3 cases of maternal cardiac arrest, and that's all I've seen in my whole entire career. And thank God I was not the assigned nurse for any of them. They were kind of what I heard when I got back to work after something bad happened and I wasn't there. It does happen occasionally. It can happen after an epidural goes too high. It can happen after a severe hypotensive effect when we have that vena cava syndrome. It can happen in moms who have pre-existing cardiac disease. It can happen with sickle cell in pregnancy. It is rare, but it can happen, and you just got to be able to move quickly. It can happen after a hemorrhage too, where you get cardiac arrest. Now, the problem is you can call code blue overhead or an adult medical emergency, whatever your place is using to designate cardiac arrest. But the code team doesn't usually have to go to labor and delivery. They go to all the general medical floors. They go to emergency rooms. They go to the operating room. They go to PACU. They go to cardiac cath. They go a lot of places. The one place they almost never go is labor and delivery. So they might not find you, which means that you need to know what to do, or at least begin to initiate care. And the care for a patient having a cardiac arrest in pregnancy is mostly the same. It differs in a few ways. The same thing that you do for any adult cardiac emergency, you start compressions right away. You're going to flatten the bed, and if you can get something hard underneath the patient, you do, and you press hard, fast, and deep, at least 100 times a minute. Same as your normal CPR, which you should all have if you're in the hospital. And you try to get early defibrillation, so somebody should be putting on pads, and that's another role for the team leader. You put on the pads. You start compressions. Remember, go fast and deep, at least 100 times a minute, just like you learned in your CPR class. The big difference here is that you need to displace the weight of the uterus off of the vena cava. If you do not do that, your compressions will not work. So you can use blankets, you can use towels, you can use a pillow, or you can use your own knee if you have to, but you get the weight off of that big vessel, because if you do not, you could do cardiac compressions, chest compressions all day long. They will do absolutely no good. You will lose both patients. The best evidence suggests that a C-section should be initiated within 4 to 5 minutes. The one case that I heard of, well, 2 cases that I've heard of, the mom was already in the OR. And the other case, they started the C-section really rapidly after. I don't know what the policy would be as far as starting CPR, starting a C-section in the room if that was, if it was too much to get the patient back to the OR. But you kind of hope that this situation doesn't happen. And when it does, just be prepared to go back for C-section emergently. And that is the last topic. So we are all finished. Thank you very much.